Thank you. Salam alaikum. So I urge you, chair and co-chair, next time to have a whole session for digital health. And Emirate Society, please, Dr. Abdullah, you chair the session and please allow us to talk about the great work here. So alhamdulillah, around 10 years ago, I started working with different things. We have around 100 publications in the field. The idea is to serve, not to impress. I'll start now. So AI and heart failure. What can we say about the topic and where can we go? I have nothing to disclose. I'm going to talk about AI and heart failure, diagnostics, technologies, biomarkers, phenotyping, especially HFpEF, which is very heterogeneous, and then implementation of changes. The introduction is obviously that heart failure is an absolute mess. There is no other word to say it. Heterogeneous, late, misdiagnosed, underdiagnosed, unfortunately. I'm not only concerned about the number that we suspect we have, but the number that we totally miss. Admission, mortality, prevalence, economic burden, and absolute disaster. Why do we need a new approach? Late diagnosis, heterogeneous disease, especially HFpEF, but also HFrEF, fragmented care, frequent admissions, and very importantly, need for proactive management. We need continuous monitoring, AI prediction, early intervention, prevention, everywhere in healthcare, especially in heart failure. This is the current unacceptable model. Slowly, these metabolic changes are happening in every disease, especially heart failure, and then we wait, and then we wait, and then we wait, maybe symptoms, and then we go to the doctor, and maybe we die. Suddenly, with a stroke, a heart attack, or acute heart failure. The model is not new. My colleagues, the chair and the co-chair, we're going to go to China and look at who is a good doctor. Please raise your hand. Who wants to be a good doctor? Very few. Khalas, I can stay as you are. Joking. Superior doctors prevent the disease. End of discussion. This is not negotiable. I like democracy when it's not black and white. Fundamentals. We have data. We never use. I didn't say we occasionally use. I said we never use. These are the people who say that in 1950 in Dartmouth, they decided what AI is. Actually, it was started in Baghdad by Al-Khwarizmi, Muhammad ibn Musa Al-Khwarizmi. Algorithm is everything we do every day. If I stop you and say, what's algorithm? You will not know. This is my post on LinkedIn a few weeks ago. Please follow me. I'm going to be cooking because all of us are hungry. Who's hungry? All of us. So the ingredients are the data and the dish is the decision. The recipe is the algorithm, Al-Khwarizm. So what's artificial intelligence, machine learning, deep learning in 10 minutes, Allah yasamaḥkum. So imagine you have an email. If the email is looking for a spasm, I'm thinking corollary, spam, then this will be AI, the overarching. If you learn over time what Dr. Abdullah and his colleagues don't like, then that will be machine learning. If actually the machine itself decides on its own, then that is deep learning. That's the best way I can do it. Don't worry about the slide. We don't have time to go over it. So what I'm pretending that I believe in is machine intelligence and human intelligence doing what we call medical intelligence. AI in cardiovascular medicine. I'll be quick. This is a paper, our latest paper, that Dr. Magdi Yaqub was kind enough to invite us to have. It's open access, so please read it. Give me feedback. Tell me if you like it or not. But more importantly, there are many, many more things than AI. There is blockchain, there is NFTs, there is metaverse. I'm not going to discuss, obviously. But hopefully when Dr. Abdullah would support us at the European Society and the co-chair and chair in the next meeting, hopefully we can have a whole session on this and show you how metaverse and others can transform healthcare. We've worked on all of this and we don't think AI should be the focus. It's rather metaverse, but there is no time to discuss this at this time. This is a journey from an excellent paper, not published by us, but by colleagues, that shows you the journey, diagnosis, management, disease severity, prediction, again, finding the patient who have the illness and then phenotyping. The most frustrating diagnosis on earth, in my opinion, is HFpEF. And now when you put the data and make the prediction, it all depends on whether the data is good, the model is appropriate to get the results that you want. Tons of gadgets, tons of them. You will not be able to keep up how many of them exist. But very importantly, all of them are worth our attention. But I will show you a paper that is in press. That's why I cannot share the slide, but if you want, I'll remove the paper. Currently, with my colleague at Khalifa University, a set of PhDs, where we're saying it's not about cool and prediction. It's about deployment and clinical impact. And we created a model that we hope will be universal. This is a very simple software, not only to help people in rural areas, maybe in Italy, in Europe, in our country and other countries, but also not only to diagnose a STEMI or whatever the arrhythmia is, but also to make prediction by simply taking a photo, imagine, and saying, ECG is not sinus. The sinus ECG could be hiding absolute disasters. So AI ECG is probably the most promising methodology for us to understand how heart failure can be completely transformed. And there is a study in the beautiful Italy, the wonderful Italy, in 1979, showing us that there is hypokinesis of the atrium with pathology, and that we shouldn't wait till AFib till we anticoagulate the patient. Nobody knows about that study. If I had more time, I'll tell you more about it. Same with heart failure. We diagnose only when the patient is semi-dead. So the area under the curve, to give you an idea, stress test EKG is 0.7. So area under the curve 0.9, 0.9 is amazing to diagnose heart failure. With all due respect to echo, you can't do enough echoes. And then the foundation of the model will become then ECG, imaging, biomarkers, wearable, clinical records, earlier diagnosis, better prediction, and very importantly, personalized care. Precision heart failure. In 10 minutes, give me a break. I'll do my best. So HFpEF, the most frustrating, understood. You know, there are people till today who don't believe it exists. I mean, I will do a lie detector test and even check on you, and maybe some of you would say it doesn't exist. And I assure you it does exist. I promise you it does exist. Because it's so heterogeneous, the phenotypes, I don't have time to show you real data the way I like. The phenotypes, by being divided into different phenotypes, not only it was more fun, the outcome was different. No time to show you the data. CardioMEMS, maybe you've heard about it. It's a measure of the PA pressure that can be installed very easily. This is the device. And these patients, hemodynamically, you can detect before they have symptoms. The outcome was remarkable and they were proactive. I love to show data, but not in 10 minutes. And then obviously an integrated approach is how we want to do these things. And this is feasible, doable. In Mayo Clinic, a normal sinus rhythm that Dr. Nadia and I would read in our hospital in Cleveland Clinic, Abu Dhabi, will have on the right side, this patient has a 73% likelihood of having AFib, 62% likelihood of having heart failure, 10% likelihood of dying sudden cardiac death from the same normal sinus boring ECG. Landmark studies, you know this guy, the Dutch guy, ECG, Nobel Prize, 1924. It turns out that there are millions and millions of patients. How many echoes are you going to do? Who has echo machine? Who has the technique to do it? Why not using echo more selectively? Sonographers in the back knows how many normal echoes do you do? Raise your hand. Tons of them. If we could select criteria to who needs the echo, efficiency, saving money for UAE, for Italy, for Europe, and for the globe. The cells have signals, ions that would change detected by deep learning. And we can have an area under curve up to 0.95, which is amazing. Using deep learning, look at this study from Mayo Clinic. 0.93 and even more to detect heart failure. But the one that ended up not having heart failure, within 4 to 5 years, they had heart failure. 4 times more to have heart failure. So even prediction is beyond imagination. You can even predict even in the ones who didn't have heart failure. Now, I don't ask you about your age. I want your ECG age. And look at this. A lady who lost weight and exercise, her ECG age decreased. This is a guy who was 53 and his ECG age dropped. Who knows why? You have 5 seconds. 1, 2, 3, 4, 5. Cardiac transplant, Nadia's topic. He had a transplanted heart, 16 years old. This is what Nadia does with the team. Amazing. This is a patient, amazing. A sister died suddenly. Normal ECG. I will sit with you for 1 hour today. You can all leave. I'll stay with some cardiologist. It's normal. Turns out, standard normal, but AI ECG, 76% probability of EF. What did the patient have? EF of 18%. This is science. Apple Heart Study, no time to discuss. New England, detecting AFib. When are we going to stop thinking and looking at the Italian study from 1979 that there is hypokinesis of the atrium, they are going to have a stroke. AI, ECG beyond traditional risk factors. AI can transform a routine ECG to the most powerful tool for early detection. And then AI can transform this routine ECG to tell us a lot more about what you can dream about having. Generative AI, which is what happened in 2022 with this whole ChatGPT, etc. Now we can use it not to replace physician, but efficiency, decision-making, and patient care. How about deployment? This is our paper. The reason why I'm not going to share the slide, it's under review. Very briefly, I made it in two lines. It's not enough to have an area under the curve. We want to make sure that you have validation, integration, and show the benefit to patient. This is what clinicians are asking for. Wake up, guys. And this is what we found. Summary of a very long paper. AI imaging, AI ECG, risk prediction, remote monitoring, okay. Emerging digital biomarkers, voice biomarkers, foundation models, automation is not there where it should be. And obviously governance and bias, no issue at all. Future, almost done. Do not interrupt me, please. Predict, prevent, personalize. P, I'll finish exactly in 2 minutes. Early diagnosis, smarter risk prediction, continuous monitoring, precision, better outcome. The future is in completely transforming this. So look at me. If you ever heard me talk about quality 20 years ago, before AI, I was talking proactive, personalized, and efficient. So look at this. An ECG telling my colleague whether the patient has, which one do you want? Kidney disease, by ECG. Diabetes, by ECG. Nature. Do you believe it? We have no right. I think it's unethical not to use digital health. Absolutely unethical. Illegal even. There's nothing called I'm not interested. Chest x-ray. Chest x-ray telling me about diabetes? Yes. Illegal. The #1 resistance in AI are physicians. Challenge me. I'll stay here till midnight. Eye exam tells you things you cannot dream from the liver and gallbladder disease. Can you imagine? This is Nature magazine. This is not Timbuktu, etc., etc. And this is, I don't know why it doesn't show, a toilet seat where you sit and you have everything you need. Massachusetts Mass General Hospital. The toilet seat for your heart failure patient. It's an ongoing trial. Closing. Heart failure remains a major disaster. AI is transforming it. AI enhanced ECG and imaging are transforming all what we do. Successful implementation should be validation, explainability. Means you need to know what this black box is. Governance and integration. And then very importantly, yesterday, blah, 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 blah. Tomorrow, predict, engage. AI is not the destination. Better care is. Predict earlier, diagnose smarter, personalized therapy, monitor and integrate. This is for someone who's interested in working with me and following me. I will make a statement that will shake this room. I, Samer Ellahham, in Abu Dhabi say, it is unethical not to apply the latest of AI if done properly, ethically, with appropriate governance. And I love you all. Thank you.
Excellent. Thank you very much.